So first off, I'd like to thank the organizers for inviting me back to speak today. I'm not sure if you know this, but I'm not sure if it's this group that's good luck or what it is, if it's just a coincidence, but in 2015 when I was invited to come, that was the first year that the Winnipeg Jets made the playoffs. You didn't have a meeting, I didn't get invited, we had a bit of a drought, I've been invited back, and we are in the playoffs again. So you are all my good luck charms. So a lot of what I'm going to talk about today has been covered in a lot of the other talks. It's been touched upon, but really having this talk delivered by a nurse and as it being the last talk of the conference, what I really want you to do is to take this talk as your homework. So I want you all to get out your paper, your pens, and I really want you to think about your own experience and moving forward what you need to do in regards to self-care, second cancers. And so I was asked to talk about self-care and second cancers, but really I'm going to talk about what you need to do to live well with your CLL diagnosis. So the literature tells us, and there's lots of different studies out there, but really what the literature tells us is that just by virtue of being diagnosed with CLL, your risk of developing another cancer diagnosis is twice as high as your age and sex-matched equivalents in the general population. So what I actually just said to someone was, so when you got your CLL diagnosis, you were punched in the stomach, and now we're kicking you in the shins. So it's a 1-2 combination. I think the most important thing that I want you to walk away with is that skin cancer is the most common second cancer that develops in patients with CLL. And the other piece is that skin cancer is preventable. So if you, this is another part of your healthcare that you can engage in, that you actually can make a difference. So the risk of skin cancer has been reported to be anywhere between 5 and 10 times higher in patients that are diagnosed with CLL. And in particular, it's not the melanoma cancers, it's the non-melanoma skin cancers. So your basal cell carcinomas and your squamous cell carcinomas. And we seem to see these more in older gentlemen who have been diagnosed with CLL. So when we sort of say older, what does older mean? So usually it's above the age of about 70, and then men are more likely than women to get skin cancers. And the important piece is that secondary cancers is one of the leading causes of death in patients diagnosed with CLL. So the three most common causes of death when you have CLL is disease progression, secondary cancers, and infection. And so if there's something that you can do to minimize your risk, wouldn't you do that? So as Dr. Kipp says, if there was only a 2% chance of it raining, would you carry an umbrella? Probably not. But if it's, say, up to 50%, you might actually be more engaged and actually carry your umbrella. So we know that when we're talking about second cancers, there's no real impact since time from diagnosis, but we know that the average time is anywhere, it's about 3 years. But it can happen before you get diagnosed with your CLL, so your second cancer may precede your CLL diagnosis. It may come shortly after your CLL diagnosis, and it may come a long time after, so when you're in that watch and wait period. And just to speak about that watch and wait sort of word, yesterday, I don't know if you were attending one of the sessions in the afternoon, the breakout sessions, I was the lurker that went to all 3 of them and just really listened to what everybody was saying. And so it's been called watch and wait and worry, watch and worry, expectant management. I really like active surveillance because active means we're doing something and surveillance means that we're looking for something. But the one that I'd never heard was wait and live was the one that I had never heard before. And I think that is really only something that could be developed and expressed by somebody who's a patient, who's been living with it. And I think that that's a really positive spin on that idea. So we also know when you get diagnosed with a second cancer, more often than not, these second cancers are more aggressive. So if you get a lung cancer, that lung cancer is in your body is going to be more aggressive because of the fact that you have CLL, as opposed to, if your neighbor gets lung cancer, it may not be as aggressive because they probably don't have CLL. We know that these secondary cancers are going to affect negatively your overall survival, so you're not going to live as long. And we know that risk of developing a second cancer, it increases as we get older. And we know this because most of the other speakers have said, if we all lived forever, we would all develop cancer. It increases as you have more comorbid conditions. So as you become more chronically ill, your body becomes weaker, and then it becomes more susceptible to getting another cancer. And the more treatments for CLL that you receive, that makes your risk also go up. So why is that risk higher? So there's the underlying immune suppression that's related to your CLL. It may be that the treatment that you received from your CLL has caused a chronic state of immune suppression. It may just be that your underlying genetics and your sort of the microenvironment of your cells just makes you more predisposed to getting cancer. And it might mean that immune environment might actually be more conducive to metastasis or disease seeding or spreading of that disease, and so then it becomes more aggressive. And then the other idea that you get some naysayers that they'll say, well, the reason that we actually see more cancers is because we're looking for them. Well, that's actually true. So the most common second cancers in CLL, obviously, as I said before, the most common is your non-melanoma skin cancers. And then really, if you look, it's sort of your usual suspects, your prostate cancer, your breast cancer, your lung cancer. And so the MD Anderson looked at a 20-year cohort of patients, and what they actually found they found 625 cancers in 550 patients. And so some patients, they'll get more than one cancer, or they'll get more than one form of skin cancer. So you get a skin cancer, you have it removed, and then you may develop another skin cancer somewhere else. And so that's where you can get multiple cancer diagnoses in one person. But overall, that risk is about 2 times higher. So there's always that risk of getting cancer after you get treatment. And so they looked at FCR treatment, 234 patients, and they found that risk, again, was about 2.38. But really, does it matter if it's 2.38 or 2.12? No, it's 2 times higher. And so the takeaway message is that when you get an immune suppressive treatment, you may develop a second cancer. But it's a risk that you weigh when you decide to take treatment. And the reason that you take treatment is because you want to live longer. And so it's going to be something, so you wouldn't say, I'm not going to take FCR, or if that's the treatment, the frontline treatment is available, because I might develop a second cancer. You have to weigh that risk. And certainly the risk is there, but we've gotten smarter. So the risk was also higher if you use growth factors, so Neupogen. So when they looked at the data, they found that patients who had received Neupogen had gotten more second cancers. Well, we actually just don't use that anymore. So we've gotten smarter clinically, and we've made some modifications. There's that risk of developing an acute leukemia or a myelodysplastic syndrome, which is basically a precursor to an acute leukemia. The median time to developing that is about 3 years after your FCR treatment. And they know that overall, if you develop a second cancer after FCR, it's going to impact your overall survival. So the factors that have been identified to be increased with an increased risk of second cancer is if you have an older age, if you have a male gender, if you have an elevated beta-2 microglobulin, and so that's it's a blood test that can be done across Canada, and it's cheap, it's easily accessible, so it doesn't matter if in Manitoba, if you live in Churchill, or if you live in Winnipeg, which is our big center, you can do that, and it can be ordered by anyone, and so it's an easily available test. Your LDH, if it's elevated, if you have impaired kidney function, so your creatinine. And then there's been some link with some moderately increased significance with some cytogenetics, including 17p, 11q, and trisomy 12. So we actually looked at, I looked at a couple of studies, and at the MD Anderson they looked at 797 patients who had been living with their CLL for more than 10 years. And they found that the risk was the same if you had your older age, if you were male, and then they found that if you had a low platelet count, that your risk was higher. At Cancer Care Manitoba, we looked at our patient cohort over a 10-year period, and Dr. Gibson mentioned this yesterday. And we found basically what the literature already says. If you have an older age, if you're a gentleman, if you're a male, and if you've had more and more lines of chemotherapy, you're at risk of getting a second cancer. And what we found was that that second cancer was more often than not to be skin cancer. So when you look at skin cancer and CLL, what we know is that skin cancer is more likely to be locally aggressive, so it's going to grow faster. It's more likely that if it's removed, if it's excised, that it's going to come back. We know that it's more likely to happen in the head and neck area, and so it can be disfiguring because it could grow quickly and it can be aggressive. And so that might actually, in removing that skin cancer, it may actually be disfiguring. What we also found, which I've already said, is the same thing. And I think it's good to say these things over and over again. The risk factors of second cancer, and in particular skin cancer, and I'm watching all these men out there and I feel bad that I feel like I'm targeting you. It's like targeted therapy. If you're an older man, your risk of getting skin cancer is higher. So what the older men in the audience need to do is pay attention and write down the things that you can do to combat that. Because the most important thing is that skin cancer is preventable. And so these are the two most common skin cancers. So you have your basal cell carcinoma, which is on your left-hand side, and that's the most common skin cancer. And as I said, these occur in your head, your neck, your ears. And the reason that we see these basal cell carcinomas on the ears and in men is because when men go outside, they think, oh, they go golfing, they stick on a visor, they stick on a baseball hat, and what's still exposed? The tops of their ears. When we put on sunscreen, we stick it on our face, we stick it on our arms and our chest, but we forget the tops of our ears. And so we leave that sun exposed. And so that's why basal cell carcinoma develops on the ears. So what does a basal cell carcinoma look like? It's a persistent, non-healing open sore, and what happens is that they bleed, they ooze, they just don't heal. But basal cell carcinomas often have around the edges, it looks like a donut. It has a rolled, pearly edge, and so we tell everybody when you get diagnosed with CLL that you should be going to see a dermatologist. But really, skin checks are something that we can do for each other. You can do on yourself. You can do most of your body yourself. But it's something that you can do at home. The second most common skin cancer is something called squamous cell carcinoma. And those often come to the sun-exposed areas. And those are really red, scaly patches. They're sort of pebbly looking. And they crust, they bleed. So what they often look like is sort of like that gray sort of, they're textured, they're a little bit sandpapery. And it may not be, you may have one already, and it may be what we call an actinic keratosis. And so that's sort of like a precancerous skin cancer. And so those can be removed, and then you just have to basically watch the area. And some of these are our patients. The gentleman, that's his ear, and the one on the face, those are patients of ours from Cancer Care Manitoba. So another form of skin cancer, and it's really the one that I think that we probably think of the most when we think about skin cancer, is melanoma. And those are really the dark brown, dark black looking, they look like moles basically, or pigmented areas. But they could also be white, pink, red, or blue. And they basically look like moles, but these are moles that are going to be changing, growing quickly. You're 2 to 3 times more likely to develop a melanoma if you have CLL, and you're far more likely to die from the melanoma. I mean, melanoma is a very fatal skin cancer. But the other piece is that when you immune suppress somebody for CLL, that melanoma can spread out of control. And so we had a gentleman at Cancer Care Manitoba who had a melanoma lesion on his thumb. And we gave him FCR, and he ended up losing his thumb because when we suppressed his immune system, that melanoma just went out of control. And so he actually ended up losing his thumb because of it. Because once you suppress the immune system, the melanoma just sort of goes crazy. And the most common sites for those are your legs and your back. So we've talked about, in one of the other slides, it talked about the ABC guide for skin cancer assessment. And it's really gotten all the way down to G. So what to look for, and you can Google this on the internet. So you're looking for basically, are these skin lesions changing? Are the borders definitive, or are they sort of ambiguous? Is the color, what color does it look like? Is it a variety? Is it an unusual color? The other, the new things, and the big one is growing. So G is for growing. And that's the thing that you can watch for, is it changing? And so when you're doing active surveillance, you can actually watch those. And in this day and age with our phones, you can actually take a picture of a lesion and then you have something to refer back to. And trust me, healthcare providers are not immune to this. I had a spot on my inner thigh. I circled it, I took pictures of it, I watched it, and it ended up being nothing. But there's something to be said for the ability to use technology to help us to monitor. So now we're going to come to cancer screening. And so often when you think about cancer screening, the onus falls on the person who needs to be screened to participate. And so in Manitoba, when you turn 50 years old, you get, if you're a lady, you get a lovely invitation for a mammogram on your birthday. And you can get the same thing for colonoscopies. But the onus falls on you to book your appointments, show up for your appointments. And so this is my reminder to you that says that your risk of getting cancer is higher. So when that invitation comes, accept it happily and participate. So often the reason that people don't go for cancer screening is because they think that their risk is perceived to be low. And so I'm here to tell you that's not true in your case. And so don't discount that invitation for a mammogram or a colonoscopy. Participate. There was a study that looked at who's more likely to be screened or to undergo cancer screening practices. So those people who are more likely are people who are married, and whether or not that's because your wife nags at you and reminds you to do it. That's a good thing for nagging. Is it because your spouse agrees to go with you as support? Is it because your spouse books your appointments for you? It doesn't matter, but we know that people who are married are more likely to participate in cancer screening. We know that people who are educated, so that isn't necessarily academically educated, but just knowledgeable. Those people are more likely to participate. If you have insurance, that's not as much a factor in Canada, but in the United States that obviously does factor in whether or not your insurance is going to cover additional screening. Those people who have a usual clinic or a healthcare team. So basically, if you have a usual place of care, you're probably more likely to undergo cancer screening. And so that's why it's really important that you foster that relationship with your family practitioner, because that's going to be your usual place of care. And then last, those people who have been told to be screened are more likely to get screened. And so I'm here today to tell you to get screened. But when you think about cancer screening, it's important that we think about overall life expectancy. So when we think about your overall life expectancy, usually they think if you're not going to live for at least 5 years, then you probably don't need to go through the cancer screening. And then the other piece is, do the benefits of screening outweigh the risks? So that's the other thing that clinicians go in, think about. So if you're on watch and wait and you're doing really, really well, or active surveillance and you're doing really well, then you should participate in cancer screening because your leukemia is well controlled, and so you need to be thinking about living the rest of your life and living it for a very long time. So the cancer screening recommendations in Canada, they're a bit limited, and so women between the ages of 50 and 74 should have a screening mammogram every 2 years. Most women aged 21 to 69 who've been sexually active should have an internal pap smear every 3 years. Quite often women, when they get to be of a certain age, sometimes it's 50, sometimes it's 60, their family doctors will say, you don't need that. Tell them that you do. Just remind them that you do, and just, I'm sure not a lot of women ask for it, but ask to have it done. And then the routine screening for men and women between the ages of 50 and 74 is for a fecal occult blood screening every 2 years. And it's not a colonoscopy in the general population, but your risk is higher. And so you should ask about colonoscopy, and I'm going to talk a little bit about family history in a second too, but you should sort of remember that your risk is higher. This is for the general population. And some people say, well, I'm not sure if I've had a colonoscopy. Then you haven't had one. It's the easiest question to answer. If somebody says, I'm not sure if I've had one, you didn't. So there's other cancers that aren't addressed in cancer screening. And so one of them is prostate cancer. And so if you look at the routine screening for prostate cancer, it says that there isn't any routine screening. You don't need to have a PSA, you shouldn't have a PSA. And so we recommend a digital rectal exam with an annual physical. A lot of our doctors just order PSA anyway. But really, for the general population, they don't need to have the extra screening. You have a twice as high of a risk, so you do need to have the extra screening. Lung cancer, obviously you should stop smoking. And that's a hard thing to do, because often if you are still smoking, there's an emotional or a psychological reason as to why you're stopping smoking, or why you're smoking or continue to smoke. And so it's often linked with your coping. And so often, and I don't tell anybody who smokes knows it's bad for you. I'm not going to tell you anything you don't already know. But what your healthcare team can help you to do is to perhaps substitute with another form of coping, because that's probably why you are continuing to smoke. But you should stop, and you know that. Oral cancers is another thing that we have to think about. So if you smoke, if you drink alcohol, you really need to have an oral exam. So you need to go see a dentist. Make sure that that toothache that you thought was a toothache isn't a head and neck cancer. So you need to have a trained professional take a look in your mouth, at least once a year. And if you are suspicious about anything, ask. And then skin cancer. You should have a total skin check by a trained professional at the time of your diagnosis, or we say at the time of your diagnosis, and then we sort of switch it between 6 to 12 years. That's probably because that's how long it takes, or 6 to 12 months, because that's how long it takes you to get into a dermatologist. But you can have, your CLL specialist can do a sort of a quick skin check on you, and then if there's something that they identify as a suspicious lesion, then that will expedite your referral in to see a dermatologist. So skin and sun hygiene. So you can get a skin check by your dermatologist. You can do a skin check on your spouse. You can check in the mirror. You can take pictures of your own body. If you have a selfie stick, you can now get your back. That's something to think about. But often what happens is that some people only get a skin check once. Well, you should, if you are an older gentleman, and or you are anyone who receives CLL treatment, you need to maintain that relationship with dermatology and go back and get checked again. Because that's important, because your risk doesn't go away after the dermatologist does a once-over and says, you're good. You're good for right now, but that might change. Other things that you can do: avoiding the sun between 10 and 4, seeking shade, putting on sunscreen as a daily habit, wearing a wide-brimmed hat. That's really important. Protective eyewear. And the other one that we often forget about is, and the reason that squamous cell carcinomas develop on your lips is because we don't put sunscreen on our lips. So if you get a lip balm with SPF in it, that actually can help you to prevent cancer. And then daily vitamin D supplements, because often people say, well, I don't take vitamin D because I get my supplementation from the sun. Well, if you actually cover your body with sunscreen, you're preventing the synthesis of vitamin D, so you should be taking the supplementation. So at Cancer Care Manitoba, we have ways to reduce your risk that our foundation talks about. So staying active. This is stuff we've already talked about. Staying active. Staying active also helps you with coping, but it helps to make you less fat. And there's a link between cancers and obesity, and cancers and obesity and hormones. And so it's important, so being active helps to decrease your fat. Participating in screening is a big invitation that is a gift, and you should participate. You should eat healthy and eat in moderation. I'm not saying cut out all red meat and go crazy. When my grandma got diagnosed with lung cancer, she ate asparagus like every day, 3 times a day. It only lasted 8 days, and then she quit that. In moderation, anything in moderation. When you look at your plate, make sure that it's colorful, that it's not all one color, that it's very colorful, and that's a really important reminder. So being sun smart, and again, stopping smoking. So what you need to do is you need to report to your clinics the screening practices that you've participated in. If you know when and where they were done, we can then pull reports, because you may not know if a biopsy was done, but we can pull those reports as well. It's important that you know your family history of cancer. So that's something that you can sit down and think about, because if your risk is higher because your brother had colon cancer, that puts you at an even higher risk. If your mom had lung cancer, also your risk for that is higher. So you need to be more vigilant and aware. And the most important thing is if something is persistent and worrisome to you, your intuition is probably right. So talk to your doctor or your nurse. In our clinic, the nursing staff is very well supported by our physician colleagues, and so we often tell the patients to tell us this information first. And if it ends up being nothing, we still log it in your chart, because that's important. So we've talked also about preventing infections in CLL, and we know that, again, that infection is a leading cause of death in individuals with CLL. Most often these are sinus infections, bronchitis, urinary tract infections, and then skin infections. There's lots of reasons for the causes of infection, but we know that your risk of infection is higher while you're on treatment, and so we talked a little bit about going on prophylactic antibiotics and antivirals while you're on treatment. Hypogammaglobulinemia is something where you have a low IgG, a low antibody. It's the most common immune defect in CLL. And we know that at the time of diagnosis, about 1/4 of all patients have a low immunoglobulin. And then what makes it drop lower over time is basically the passage of time, and chemotherapy also suppresses your immune system. So at Cancer Care Manitoba, what we look at is your eligibility to replace your immunoglobulins is if you have a low IgG and at least 2 courses of antibiotics in a year. So just the fact that your blood result is low isn't reason enough to get replacement. You also have to be bothered by persistent infections. And so Dr. Gibson talked yesterday about the fact that we now use subcutaneous. Some of you might be getting IVIG. So what happens is basically when you do subcutaneous, you just actually do the infusions into your fat tissue. You do it more frequently, and you're able to do it at home. And because it's a slow absorption and it's more frequent, it actually, giving it subcutaneously mimics the body's production of antibodies, as opposed to giving you a big bolus dose and then it wearing off, so you don't get that effect. The other great thing is that you don't need venous access, which isn't as much an issue anymore now that we're moving towards more oral therapies, but it does save your veins. And the literature and our experience has been that there's greater patient satisfaction, greater independence and flexibility. So it's now our standard of care. We're the first cancer center in Canada to offer training and monitoring in-house by our hematologists and the clinical nurse specialists. Since 2014, we've enrolled over 100 patients, and about 88% of all patients either choose this option or are eligible for the option, and very few, once we start them, actually switch back. It's very, very well tolerated with very minimal side effects. And we actually use a low-dose approach rather than weight-based. So we give you the least amount of replacement that you need to prevent you from getting infections. And then if you do, we just sort of escalate up as opposed to starting high and dropping low. And as Dr. Gibson mentioned yesterday, we've noticed a 3-to-1 reduction in antibiotic use, so your infection risk is going down. We also looked at a retrospective review of patients over 10 years, and we were able to determine that about 7.5% of all patients end up requiring immunoglobulin replacement therapy of some sort. And the mean time to replacement is 65 months, so about 5 years after their diagnosis. That's when most of our patients went on. We found that an abnormal IgG at diagnosis, so either your IgG is too high or too low, that actually was predictive of your need for replacement immunoglobulins. And we found a link between your IgA. So if you had a low IgA at diagnosis, it was also significant for your need to getting replacement. The picture is just actually a picture of a local site reaction, and so that's actually what the skin looks like. It gets a little bit pink, but I tell patients it's not very anything, not very painful, not very uncomfortable, not very itchy. And as you can see there, that the side effect profile is much more desirable for sub-Q. So there's 2 ways to give it, which Dr. Gibson sort of talked about. There's a pump and there's the rapid push. Rapid push is much cheaper and it's much easier to teach patients to use this. And it's really good with the secondary immune deficiency patient population because you can use smaller volumes, and that's often what we've prescribed for you. And it's also very good for travel. So this is a picture that one of the patients emailed to me, and this is the beach in Mexico. So he's on sub-Q immunoglobulins, and he went down to Mexico for 6 weeks, took his immunoglobulins with him, and was cheeky enough to send me this in Winnipeg when it was like -38. So once I got over that sting, I was incredibly happy for him, and it just makes my heart happy to get pictures like this. This is a completely just a review of every other talk that's been given or comment. You should get your flu vaccine every year, and your caregivers should get your flu vaccines every year. I put live vaccines are discouraged. I didn't say anything about Shingrix because in Manitoba we're not exactly sure what to do, but again, live vaccines should be avoided. Pneumococcal vaccination, you should get your pneumococcal vaccination at diagnosis, and then you're going to need a booster. There's 2 different kinds of pneumococcal vaccination, and so it's important that you get the conjugated and then followed up by the polysaccharide. And the reason is that what the conjugate does is it activates your T cells, and then you follow it up with the polysaccharide. And so you just get more effectiveness when you use this 2 vaccine series. So you should become familiar with all of your lab results. You should keep a record of your infections and the antibiotics that you're prescribed. If you notice that your record or your log's getting long, call your CLL specialist and report that to them. Make sure that your immunizations are up to date and current, as are those of your caregivers, because the only way to get rid of your infections is to put you in a bubble, and you can't do that. But what you can do is create a bubble around you. And so if all of the contacts in your home have been immunized as well, that's like creating that bubble effect. So self-care and coping, we've already talked a lot about this at a lot of the sessions. And the biggest thing that you grapple with is uncertainty. And it's that not knowing, not being able to predict your future, not knowing what to do, not knowing what to expect, not knowing who to trust is a big issue. And so we've already talked about coping strategies, acknowledging your fears, knowing obviously that you're not alone. And obviously by this room, you can see that you're not alone. Seeking help, joining a support group, and educating yourself, which you've already done. The big thing is that we've asked caregivers to become to assume this primary role, and you're not given any training or formal advice on how to do this. And there is a burden that's associated with caregiving. And so even having your caregivers educate themselves and becoming masters will help to alleviate that burden. So if you are here alone, go home and make yourself vulnerable and maybe share with a family member or a friend, because creating that mastery in others helps to decrease the burden. We've already talked about staying well. The one other piece of coping that I don't think has been addressed is take time when you're sad to experience that sadness. Allow yourself to grieve your losses, but do it in a time limited area. So if you're feeling sad, the best advice I was ever given is when you're feeling sad, go to your go-to sad movie, watch it, cry, ugly cry, and when that movie's over, get up and get over it. Just like the way the movie's over, your sadness is over. And then gain control again, go out, exercise, do something, talk to somebody. So in summary, your risk of getting second cancer is higher than the general population. Most often that's skin cancer. And standard screening guidelines are not enough. You need to be hypervigilant. You're also at risk of getting infections. I'm like Debbie Downer. This is a terrible way to end the conference. Your risk of getting infections is higher, but there's something that you can do about it. Get your immunizations. Talk to your practitioners about immunoglobulin replacement. And making a log. Logs are really important. And then finally, collaborate with your primary care and your CLL specialist, because that's really important, because really it's teamwork and you are a vital member of the team and you can educate and coordinate your care. Thank you. So the question was, how often do we recommend seeing a dermatologist after treatment? So there's not really a recommended guideline, but you should get referred at the time of your diagnosis, and then maintaining a relationship. So at the time that you're getting your CLL treatment, you probably should go in, it's probably not something you're going to want to do while you're on treatment, but if you're getting FCR, after you finish your FCR, you should go back and get reassessed. There's not any real guideline that tells you that. Well, that's just the thing. More often than not, if you can get in to see a dermatologist, they're going to maintain that relationship with you and you'll just go back. Or they'll say that they'll see you back if anything should develop. Some dermatologists are so busy that they don't necessarily book you in for, an annual screening test. But we recommend at Cancer Care that you go once a year. Or we've also become subspecialty, although I joke that we just carry the dermatology textbook. And if it's not in the textbook, we don't know what it is, and we send you to dermatology. But your CLL specialist is also, they're doctors, so they can screen for skin cancers.
This is a follow-the-money question based on the home infusions. Yeah. In that circumstance for Ontario or Manitoba, do you know whether the cost is covered as it is in the hospital infusions? Or do you have to actually pay for the...
For subcutaneous?
Yes.
So it's a blood product, and in Canada, we don't charge for blood product, and so it's dispensed from the blood bank to you at free of charge.
Thank you.
The only thing that you may be charged for would be the ancillary supplies, and so that's often why some clinicians will choose doing the push method rather than the pump, because obviously the pump and the tubing costs more. But if you do it by the push method, it's literally a syringe and a butterfly tubing. It costs less than $1.30 to do that. And so at Cancer Care, we just dispense that for you. But that would be all that you would be charged for. You would not be charged for the blood product itself.
There was a question, there were some numbers near the beginning of the presentation regarding the likelihood, let's just say twice as likely in 4 years. Do you have any kind of statistical numbers of a drop-off after that in terms of the possibility of getting secondary cancer?
No, the risk is inherently going to remain because your CLL isn't curative or curable. And so even if you get chemotherapy and you put the CLL into remission, it's then the treatment that can cause your risk. So the risk really never goes away. It doesn't sort of drop off and go away.
So it's still, just for the sake of argument, say twice as likely forever.
Yes.
Right.
And then if you get treatment, then the risk increases from there. But your baseline is basically twice as likely.
Right, thank you.
I think there's one other question, and then we'll call it out.
This is more in terms of a comment, but I didn't hear anything about the method of treating SCCs, which is the squamous cell, which we're very prone to get. My dermatologist is working with a CLL specialist in a study on skin cancers for our community specifically. And he is very adamant about how an SCC should be removed, and probably others, but because there's a lot of treatments using ointments and sprays and different kinds, and he said that the location and frequency of your SCCs is very, very important. And I had one on my shoulder, which was really tiny, and I got a scar. It's about 4 inches long. So this is a very potentially serious cancer that's not considered serious in most patients who don't have our CLL. So I just wanted to
No, that's a really important comment. Thank you. And I'll just sort of take you back to when you were diagnosed with CLL. There has to be at least one person in here that thought, cut it out. Let's just cut it out. But it's your blood, so you can't. But a squamous cell or a skin cancer is the one thing that you can actually just cut it out. And that's the best thing that can be done, is that it can be actually excised with wide margins to make sure that they've gotten all of the cancer, and then monitoring. And you may need radiation, you may need chemotherapy, but it is the one instance where you can actually just say cut it out, and that's the best thing to do.
I just want to add to that. So this is, it's really actually very important, Wayne, that he brought this up, because, even though we talk about melanoma, squamous cell is much higher in our patient population than melanoma is. It's not to say melanoma is not higher, but in general, the squamous cells are certainly the ones that cause us trouble. And it's not just the chemotherapy. Everybody thinks it's just FCR. It could be patients on ibrutinib. It could be, so this is one area that I'm a pretty staunch believer that you have to go to derm at least once a year. Clearly, if they tell you to go more often because they see something, listen to them and go more often. I review all the derm reports on my patients. Because if they've gotten, except when they freeze them, because there's nothing to review. But if they got something cut out, I want those reports, because I want to make sure that they've gotten the margins and that they've done what they're appropriately. Because like all offices, we all screw up, and sometimes you don't get them and you don't know, and you say no news is good news, but then you forget, and then you see and you go, oh, you know what, that extended into the margin. They need to be re-excised. So it's really, really important to stay on top of your dermatology.
It's also one of those things that you should report back to your clinic.
Yep,
if you
absolutely.
go to dermatology,
Bring the report.
cut something out, tell them that they biopsied something, and then we can then do our due diligence and pull the report if we didn't get it. Because in healthcare, just because we didn't hear it doesn't mean it was nothing. So.
Fantastic. Thanks so much. So just a few minutes keeping you from boxed lunch, I think, is available for you outside if you would like. Just like to remind people to fill out their evaluations if they could. It's helpful to the organizing committee to plan the next meeting. I'd personally like to thank all of the speakers, the organizing committee, advocates, patients, all of you who participated in this meeting. I really think it was, again, another wildly successful meeting. Thank you for such engagement in the conversation and discussions that we've had. It's a real privilege for me to continue to be involved in this meeting. As I said, I think it's a unique and special meeting, and look forward to seeing all of you in 3 years or so time. And I'm going to turn the microphone over to Jim Burke to close the meeting for us.
Thank you, Dr. Fraser. And thank you for keeping us on time and making this one of the best conferences that I've ever been to. I'm Jim Burke. I am a CLL patient, and I was treated with FCR by Dr. Carolyn Owen, and I am just thrilled. I'd like to thank everybody for coming and making this such a great event. without you all being here, we would be talking to ourselves. I wanted to thank all of the speakers. I learned a tremendous amount of things through the conference today, this weekend. Some of the things that I'll remember that I'll take away from this conference is Dr. Kipp saying, "Knowledge is power." Mark Silverstein saying, you don't know what you know. You don't know what you don't know until you need to know. And just the idea that we have oncolytic viruses. It's like that was a highlight for me. So I'd like to thank Dr. Fraser, Dr. Lamanna, always very wonderful to hear all your explanations. Never too long. Dr. Owen, thank you for everything you've done for me and for everything that you do for research and for this conference. Dr. Banerjee, Dr. Kipps, it was great to hear him. And Dr. Gibson. Dr. Gibson is one of our scientific advisors, as well as Graham, and it's great for all the work that's being done in Manitoba and everything that you've been able to pull together. And Stephanie and Esther and Christina for running the different groups. Those were really fun and very illuminating. And Erin for secondary cancers. Of course, now I realize that I got something on my chest that I'm going to have to go have looked at. So you've been a great audience. It's been a great discussion, and knowledge is power. And through the last few days that we've spent here, we have all gotten more knowledge. So that I'm hoping that you're leaving with a better understanding of your CLL, and also for all the caregivers on how to support your CLL patient. The last thing is on each of these tables, we have beautiful flowers. So anybody who would like to take the flowers home, please take them home. Otherwise, they'll just be thrown away. And so safe travels, and I wish you all the best in 2018, and I hope to see you again when we put this on again. Thank you.